Hello, my name is Jonas, and I would like to talk about HIV prevention in transgender people today. Before I start, I would like to acknowledge the Maastricht HIV lab, first and foremost my collaborator Dr. Sarah Stotterheim, Hao Yiwang, and Dr. Mart van Dijk. Also the EU Flash Prep team with Ed and Coalition Plus, Rosemary de Labre, Adeline Beignet, Richard Stranz, Vincent Schlegel, Bruno Spier, and Daniela Rojas Castro, and of course all trans people who participated in our research. We recently published a meta-analysis on the burden of HIV among trans people, and the results are problematic, or in that sense, they show that trans feminine individuals have a really high burden of HIV prevalence compared to all adults, and also for the first time we investigated this among trans masculine individuals, and there the burden is also considerably high. What's also important to note when we look at the HIV prevalence among trans individuals is that the type of sampling method has a huge impact on the HIV prevalence estimate, and that can vary between 1 to 3 times as much depending on the type of sampling. So we really need to take into account the type of sampling, and we really need to increase data coming from surveillance, also NGO, but also hospital data, because most of the samples are coming from respondent-driven sampling, and there are quite big differences, so we really need to have more robust estimates. What is also important, and that has been shown in other meta-analyses before, is that there are regional differences, and those are vast. In our meta-analysis, we could show that the prevalence is higher in Africa and in Latin American contexts, and lower in Asian and the global North context, but still overall the burden is considerably high and much higher than the cisgendered population. But besides this general statement, when we talk about HIV prevention in transgender individuals, we need to look at a number of topics, and I would like to address them bit by bit. Before I turn to PrEP, we need to see that there is interest in PrEP by transgender people. It is growing and is documented, and it's really something we need to take into serious account. There is diverse data also within a geopolitical region, for example, the Southeast Asian region, and there are time differences. If you look at early data from 2016 from Thailand, interest was at about 40%. At the same time in Vietnam, much higher. Recent data from Malaysia shows a much higher interest, and data from the US also from this year shows considerably high interest. In the European context, data is scarce. We investigated this in the EU Flash Prep survey in 2016, but you can see among the almost 16,000 respondents in the survey, we were only able to reach about 247 transgender individual. And this shows that also the sampling approaches for oftentimes these surveys are not really geared towards transgender individuals, and we really need to do much better to increase the numbers to get better data and better predictions coming out of this. What is interesting, if we look at the EU Flash Prep survey from 2016, is that a lot of trans individuals, both trans men and trans women, judge their perceived HIV risk as rather low, and only a minority judges it or perceives it as high. But then if we look in a multivariable model, there aren't a lot of tangible indicators left besides HIV risk that predict interest in PrEP. So there is really more research needed, and there is also sort of more transmission of knowledge needed to really make trans individuals aware of their HIV risk, so they are not underestimating their HIV risk and leave PrEP prevention opportunities to the side. We need more PrEP cascade data. There is data available from the US, and these are oftentimes the few really robust data. And this is also something we saw in our meta-analysis, that the majority of the data is still coming from North American backgrounds, which is fine, but there are also trans individuals and a lot of trans individuals living outside of the North American context, and we need to have data on them to better tailor prevention efforts for them. There's a notable example, data from Thailand that has a PrEP cascade investigated for transgender individuals. And what's interesting here is that the same cascade they investigated for MSM is not so much different than for trans individuals. So the bigger difference in the cascade is by age, and we see that younger trans individuals are less likely to start to take PrEP and to also stay on PrEP. Retention rate is lower, and it's get better with a higher age, above 25 years of age. And that also mirrors the data that we found in the European context, where age also played a role. But overall, PrEP acceptance didn't differ very much between MSM and trans individuals, both around 44% in the Thai context. But that clearly shows that we have work to do, especially when it comes to younger transgender individuals. And here, transgender women, this cascade wasn't available for transgender men. PrEP uptake remains low. In our meta-analysis, we didn't find a PrEP effect, which most likely is due to the articles that we could sample, the data that we could sample, which is oftentimes prior to an introduction of PrEP in the countries investigated. But also more recent primary data from the US shows that uptake among a trans population is low. It was a bit higher in Brazil. And there is also oftentimes low enrollment of transgender individuals in demonstration projects, for example, the UnPrep project in the Netherlands. So besides interest, uptake really remains an issue, and we really need to work on this, but we also need to identify why the uptake remains low and what we need to do to change that, and so that we can increase this. There is oftentimes eligibility that is a hurdle, and there is a risk and uptake gap. Let's look at the eligibility first. For MSM, PrEP eligibility is a function of sexual behavior related set of criteria. That is most of the time risk exposure and experience of STIs, bacterial STIs in the past 6 months. But for trans individuals, the picture is more complex, and eligibility can be linked to stigmatizing assessments of the sexual identity and sexual behavior. A colleague of mine, Jay Svelius, has already pointed to this a couple of years ago. It's oftentimes that trans individuals are being categorized as MSM, and then if that categorization is not correct, which it is in a lot of cases, then eligibility becomes sort of a meticulous assessment of sexual identity, and not only of sexual behavior, which is where the risk is coming from. Furthermore, the eligibility is often tied to risk exposure, which for some trans individuals is tied to seasonal exposure, especially when it's related to sex work. And in that context, an assessment of the low risk period could actually lead to a non-eligibility. On top of that, the anatomical complexity between a neovagina, vagina, and anal contact increases the counseling demands, which is, for example, related to a possible PrEP regimen. Is daily or on-demand indicated? What delivers the best protection? But also here, we need to understand what is our point of departure. Is our point of departure 100% protection, or is our point of departure of any protection is better than no protection? And if we start from the latter, then any kind of protection, any kind of PrEP regimen can be helpful. But if, of course, we perceive we need 100% protection, then this could be quite a difficult narrative. The risk uptake gap has been pointed to also. There is in data, for example, from the United States, trans individuals, about half of them were indicated for PrEP use, but only 20% used PrEP, and 11% had used PrEP in the past. So there is quite a substantial gap between the eligibility, the indication for PrEP use, and the actual PrEP use. And this is really something that we need to address, and we need to close this risk uptake gap and really investigate how we can construct eligibility for trans individuals in a non-stigmatizing way, so that sexual identity is not continuously co-assessed with sexual behavior. There is a big topic in the context of PrEP and trans individuals, the assumed and feared treatment interaction between hormones and PrEP. And I think this is really something where we as scientists are the culprit for this scare, or for this seed of fear. There were concerns, there was initial questions out there, and that led to the assumption and the fear among transgender that PrEP is less effective due to hormone treatment, or that hormone treatment is less effective when taking PrEP. And I think a lot of healthcare providers have difficult to understand this concern, because the scientific evidence now is very clear. There is no negative interaction, so that there is no risk. But for trans individuals, that is very much of an issue. It's very much of a concern, in that sense that a less effective hormone treatment is really touching the very essence of their being. And hence, this is really very important to them, which, again, a lot of healthcare providers can't understand, and just keep an assumption up and out there that HIV prevention would be the primary concern. We also see in recent data that supervised long-term hormone use can actually be a driver too, in a positive sense, for PrEP use, and not a hurdle. So this is something we can learn from our colleagues in Malaysia. We also have good news. There is a good adherence in some studies reported, for example, from Brazil, 74% of adherence, more than 4 doses for daily PrEP. But we really need to understand that we need sort of systematic reviews for both topics, namely uptake and adherence, and those require a culturally and regionally nuanced analysis. We have a number of known determinants. There are abundant lack of knowledge, cost, healthcare provider stigma, but we also are facing inconclusive data. For example, depression and substance use in some studies have been shown to be a determinant for low adherence for PrEP use, and in other studies have been shown to be a determinant for high adherence for PrEP use. And we have to take into account that there are a number of very specific regional contexts that play a role, and that are really unique to the context they are investigated, but that also requires specific investigations. We can't just transfer any kind of knowledge from one part of the world to the other. For example, the Sino Malay in Malaysia have a lower uptake, and this is a very specific group in the Malaysian context, but we really need to investigate and discover, unravel such populations that require our specific concern and attention. When we turn to another type of biomedical prevention, treatment as prevention, and the HIV cascade, we have to recognize there is a global south-north divide, in the sense that a lot of data is only available, again, for Northern America. Sometimes even there it's not very recent, or it has small sample sizes. The studies from Glembilo Santos and also the colleagues from JIN, they have sometimes around 100 participants or 65 participants. So again, here we need larger and more robust data. And these warnings have been out there for a number of years, that transgender women are basically falling off the treatment cascade because we're not investigate them separately and throw them together with MSM populations. And transgender men are even overlooked more because they are, again, lumped together with transgender women, or not differentiated in other forms. In the Global South, oftentimes we do see that MSM and transgender people are reported jointly, which doesn't allow a trans-specific investigation. And these cascades are concerning. And we see, for example, in the Peruvian cascade for 2017, a very steep drop between the infection and the diagnosis. And even if we assume that there are no big differences between MSM and transgender, this really shows that we need to do something for both, and in particular for transgender groups. And the same picture comes up in the context for other contexts for Rwanda, for example. And you do see that, again, here MSM and trans are being put together in one group. But it's really an issue that we need to disentangle that. Let me sum this up. HIV prevalence and HIV risk among transgender people is high. Our recent meta-analysis confirms this. Again, there is not yet an impact of PrEP in this context. We don't have specific data for an HIV cascade because we have the false assumption of that MSM and trans individuals are the same in terms of HIV risk. PrEP should be available for transgender people, and we need to really look at the eligibility construction so that we do not investigate sexual identity jointly with sexual behavior and the associated risk-taking. We really need to close the existing knowledge gaps in the transgender populations and communities, and we need to make PrEP available, covered by health care insurance, or at a very low payment cost so that we don't create unnecessary hurdles. And we need, of course, transgender sensitive, stigma-free healthcare providers. I would like to end this presentation with a current concern. The Ukraine crisis is also affecting transgender individuals. UNAIDS reports that there are about 8,000 transgender people living in the Ukraine. They are at a very high risk for HIV and only have a 53% HIV status awareness. And what makes the situation for this population even more problematic is that they often cannot flee, because if your passport shows that you are biologically male, then you're not allowed to leave the country because of drafting regulations. But you could be presenting as female, as a trans individual, and that is not being recognized. So there is really a very worrisome situation for trans individuals in the Ukraine, not getting tested, having a high burden, but also being caught within regulations of drafting. So this is something that we need to look into. Also, we need to support trans individuals that have fled the Ukraine, and we should make available PrEP available to them, and HIV testing. Thank you very much for listening, and I'm looking forward to the Q&A coming up. Thank you very much.